for the time factor, I will introduce only 2 cases. I will present only 2 cases only. Thanks again to the organizing committee. Since we introduced our GTD clinic as the first sub-specialized clinic in Egypt, we now recruited about 400 cases. So you can say the incidence in the Middle East may be as the same as or even more than Southeast Asia. The same numbers also come from Saudi Arabia. Yes, again, thank you to the great speakers. Actually, they visited Mansoura GTD clinic 2 years ago. Thank you, Van Tromen, thank you, Baljit, thank you, Navid Sarvar, and thank you also for Christiana Lok. We have met many difficult cases, and actually, I noticed that the mismanagement or delayed management due to poor knowledge of our colleagues in management of GTD cases. So I hope this educational activity and the other educational activities we performed in Mansoura will help in clarification and helping our colleagues to diagnose and properly manage GTD. First case. I will present this case with 24 years old lady with present to her gynecologist with abnormal vaginal bleeding without reporting a previous history of missed period. No history of contraception, she is medically free, and on examination cervix and uterus were free, and hemoglobin was 10 grams per deciliter. Her gynecologist gave her non-specific homostatics, and unfortunately he didn't think to check HCG. 6 months later, the bleeding continued also. He performed transvaginal ultrasound. They found focal myometrial thickening, and the radiologist interprets the lesion as adenomyosis or degenerated myoma. This is a photo of the case. You will find the anterior wall of the myometrium show focal thickening with increased Doppler activity that was misdiagnosed as fibroid. Hysteroscopic endometrial dissection, I think one slide dropped here. She performed D&C, which present as abnormal proliferative endometrium, and no suspicion of any malignancy. 6 months after medical treatment, bleeding increased, so she visited another gynecologist and advised her to do hysteroscopic endometrial dissection. But during the procedure, he encountered with severe vaginal bleeding. He aborted the technique and gave her blood transfusion and resuscitation. When we checked her hemoglobin, she was deteriorated because hemoglobin was 6 grams per deciliter. And finally, an urgently performed abdominal hysterectomy was performed, and they were surprised when the histopathology of the case that she was invasive mole. Then the case was sent to Mansoura GTD clinic for the first time. We performed HCG check in blood that was 550. This HCG was checked for first time after 2 years of complaint, 2 years of medications, 2 years of surgical interventions. So the case, we checked the metastasis that was free, and we categorized the case as low risk GTN, and after hysterectomy, HCG became normalized after 2 courses of methotrexate. Now the patient is doing well. May I ask the colleagues, the speakers, and our colleagues here in the session to some points in discussion for this case. We'll discuss case by case to still remembering the data of the case. First question, now 4 gynecologists manage this case without asking, without thinking to do HCG check, either in urine or in blood. Is this due to lack of knowledge, lack of awareness of patient and gynecologist in Egypt about GTN? Dr. Van Trommel, is there any rule of ISTD and AOTD to increase awareness of gynecologists about this, about management of GTD?
Yes, Professor Hemida, I think this is a clear case of a patient who has had a prolonged interval until the proper treatment was installed. And I think in case of these rare conditions, it's always good that people are at least aware of the diagnosis. But the problem is, if you don't know about it, you will not think about it. So indeed, there is a role for more education, and it's also very important that there's now a GTD center in Mansoura, where people can go to and ask their questions. And of course, the international societies are always very happy to help out if you have a case of suspected gestational trophoblastic disease and you don't know how to manage that.
Thank you very much. The second question for Christiana Locke. In this case, performed D&C without appearance of the lesion, which is very logical because the lesion is deep in the myometrium. And also TVS was misleading. So this will make a difficulty in diagnosis of this case. What would you recommend when you face this case in your clinic, Dr. Christiana?
Well, I think you already pointed out that the HCG measurement is really important here. Often you do find some tissue in the uterus, so uterine biopsy will lead to a diagnosis. But the HCG is most important here and will help you to at least consider this the diagnosis. And ultrasound can be really difficult, certainly if you do not see a lot of moles, partial moles or invasive moles. In the Netherlands, we do not have a lot of invasive moles because I think almost 100% of all pregnant women get a early ultrasound. So diagnosis of molar pregnancies is really early, has really shifted. But I can imagine that it's really different in your country. It starts with a young woman who's bleeding, measure HCG. And that's not even only for molar pregnancy, but also as like spontaneous abortion, you probably measure it. So that's a shame that it hasn't been measured before. I can understand that it was missed on ultrasound.
Thank you very much. So my conclusion for this case, for my dear colleagues, please consider HCG check as first step in diagnosis of any case of abnormal uterine bleeding. Mr. Chairman, do you want to add anything?
No, I totally agree. I think in cases of persistent or recurrent bleeding with full investigations negative, you should first ask for it, which is routine and easy test. I would say the first point you raised was awareness that gestational trophoblastic tumor, in particular invasive mole, could be in a small minority and could be missed by others. The other thing is if Doppler is available, but again we'll need awareness. So put it into consideration. If you search for it, you'll find it. Thank you very much.
Thank you, Mr. Chairman. Any other comment from audience?
I just wanted
to
comment.
Yes, Dr. Kool.
Okay. We'll have discussion at the end. We haven't gone into that, but these are just during his discussion. He has asked for expert opinion. That's fine. So if you conclude your second case, and then we'll open the floor for discussion.
Okay.
And we still have around 20 minutes.
Yes,
so.
Dr. Kool. After the second case, okay, you are welcome. Second case also. Can you move the slides, please? Okay, we move to the second case. A lady aged 45 years presented to our emergency unit of Mansoura University Hospital with picture of ruptured coronal pregnancy. Our colleague performed coronal excision and uterine repair. Your histopathology was disturbed cornual ectopic pregnancy. This is histopathology of the case. 2 months later, I mean after very short period, presented to a private clinic with abdominal pain, some intraperitoneal hemorrhage, and abdominal enlargement. And also, again, the sonographer misdiagnosis as complicated uterine fibroid. Urgent laparotomy was done at a private clinic, of course, with less standard of care, with not well-equipped conditions. And our colleague couldn't perform any more than biopsy because the mass was friable, vascular, and a lot of blood loss occurred during surgery. Immediately post-operative, he sent the case to Mansoura University Hospital. This is the ultrasound of the case. As you see, large friable hypoechoic mass occupying most of the uterus. And the biopsy taken by this colleague performed, as you see, choriocarcinoma. So choriocarcinoma developed after cornual ectopic pregnancy, just only after 2 months. This is HCG, also the first time to be checked in our unit, more than 3,000. This is the post-contrast CT scan of the patient that revealed a lot of pulmonary basal metastases. This is our paper sheet of the case. So 2 weeks later, we performed all workup of the case, including chest CT, CT pelvic abdomen, brain CT, and we categorized the case as high-risk gestational trophoblastic neoplasia, and we asked the patient to go to the medical oncology, clinical oncology department to receive EMACO. But actually, during preparation, laboratory preparation to receive EMACO, she developed severe melena. Her blood pressure was low. She received the blood transfusion, resuscitation. Urgent colonoscopy was performed that revealed multiple intestinal superficial ulcers that interpreted also by a radiologist as mostly due to mesenteric lymph node infiltration. They postponed chemotherapy due to poor general condition, and this case was in 2016, so this is before ISSTD recommendation of giving low-dose induction AB to high-risk cases. And unfortunately, 1 week later, the patient died even before starting the chemotherapy. I conclude the case again, a case of cornual ectopic pregnancy. 2 months later, she developed choriocarcinoma at the site of the lesion, rapidly invading whole the uterus, causing intraperitoneal bleeding, mesenteric lymph node metastasis, mesenteric intestinal ulceration with severe melena, finally deterioration of the patient, and the death before start of chemotherapy. Dr. Christian, look, this is the case of GTN after ectopic. It is a rare condition, but how to suspect?
It is indeed quite rare, but again, not dropping ATG, which you probably will measure if you have your pregnancy to make sure that you removed all the pregnancy tissue. Would maybe lead you to the diagnosis, but this case is really rare because that mesenteric lymph node invasion, I can't remember many cases with this presentation, so I'm not sure if earlier recognition would have resolved everything, but you already pointed out, and which is absolutely true, is that they are so vascular, these tumors. So if you start with EMACO, it may bleed because of the necrosis of these tumors. And also in parts of the world, we have lost patients because of extreme bleeding, and that's why the ISSTD now advises to start with low-dose EP and then continue with Emaco after the patient has been stabilized. But this is quite rare. Yeah.
Okay, thank you. We'll move to the second question. I will ask Dr. Baljeet. Sometimes we find very aggressive form of choriocarcinoma, rapidly developing, rapidly metastasizing, and the fatal condition. How to predict these aggressive forms?
So thank you for the question, but unfortunately, I do not think there's an answer that we can predict as which will behave in an aggressive fashion and which won't. There has been studies which have been done on whole genome sequencing and epigenome sequencing of choriocarcinoma cases, and one of these cases, which was completely sequenced, showed that the mutations or the abnormalities were matching with an early stage of placental development in the fetus, which is responsible for very aggressive invasion of the uterine wall. So choriocarcinoma inherently by its nature is a very aggressive tumor. And we know from the review of the literature that in certain cases it can metastasize within weeks or it can take years. So because it has this hematogenous dissemination, they can just metastasize. So we do not have a marker for prediction of aggressiveness, but I would again think that HCG monitoring would help. And one comment which I wanted to make regarding the histology, that there were no chorionic villi identified in that fallopian tube when it was sampled, as I saw from the report. So that should have kind of raised a bit of alarm that was it genuinely ectopic pregnancy or is it atypical trophoblast which needs following up and monitoring of HCG levels.
Thank you very much. The last question for the speakers and also for our colleagues, and I hope one of the medical oncologists will be with us to answer. If this case in your clinic, in your hospital, what to do to have better outcome?
Yeah, we don't have any medical oncologist herein, but you said there is a recommendation to start. Oh, you have? Okay. Would you please speak in the microphone beside the Reda? Okay, good.
Of course, this is an unfortunate case, and there is mismanagement in the local hospital at the beginning. However, low dose of chemotherapy, as you mentioned, as all the protocols now adapted, could save this lady's life.
Thank you very much. Dr. Van Trommel, do you have any comment about this case?
Well, I think that much has been said already, and I think this is a case that if you were suspicious, that it might have been helpful to just discuss it in a greater team. But again, if you don't think about something, you will not seek for advice. So I think maybe the cornerstone is knowledge, and also I think maybe the pathologist could have helped a bit in this case, but that's what Baljeet already pointed out.
Thank you very much. I will only present these two cases, and because of time factors. But I have a question from our online colleagues to Dr. Baljeet. What is the criteria of diagnosis of placental site trophoblastic tumor when HCG is negative?
So as I said, 80% of these placental site and epithelioid trophoblastic tumors, they present with high HCG values which are detectable, but 20% of these might not have HCG which is detectable. The criteria again would be if you are seeing a tumor in a young reproductive age group female, and even if it's HCG negative, we do get curatings at times, thinking that these tumors could be fibroid, and these show the intermediate type trophoblasts, which are monomorphic, and they are breaking through the fibers of the myometrium and traversing the myometrium. We definitely would look for mitosis in these tumors and do a Chi-67. Literature on Chi-67 is varied, but if you see anywhere between 1 to 2% is expected to be normal, but more than 2% of Chi-67 proliferation index is definitely abnormal, and one should be thinking about these tumors in those scenarios.
Thank you very much.
They are extremely rare, so they could be sent to an expert if needed for a second opinion.
Okay, thank you very much. Any more question? Okay, you want to comment?
I have a question to Dr. Bajit. I think we read your paper in Lancet, which you co-authored this paper, and I wonder, you did BDL1 for a couple or few patients with colon carcinoma, and the paper showed that Pembro has some effect. How you measure that, and is it a routine in your service to do that? And can you elaborate more about it?
Sure. So it is not a routine in our cases as yet, and we are in a process of standardizing an ICCR data set with international collaboration, and we discussed that in that meeting in detail as well. This is not supposed to be a routine practice. What we do for these patients are the ones which are not responding to the standard lines of chemotherapy. They have failed their first line, second line, third line chemotherapy, and when we say that probably they have exhausted other options, the Pembro is then thought of in those cases, and it has definitely salvaged a few of our patients who had a really bad outcome as a result of chemotherapy. So at the moment, when we do PD-L1 staining, what is known in the literature and is known from our paper is that most of these gestational trophoblastic tumors, they would express PD-L1 in abundance because that is the mechanism the trophoblasts use to autograft itself into the, as a graft to get into the mother's body. So they try and evade all the normal immune system. So these cells, all of the trophoblastic tumors, can have more than 90% of PD-L1 expression, and that does not necessarily dictate that they would respond to Pembro treatment. So we did have a few patients who were beautifully positive with PD-L1, but they didn't respond to Pembro, whereas others did. What we found as a result of our paper is that if these tumors are expressing T lymphocytes, the tumor infiltrating lymphocytes are there, and if these tumor infiltrating lymphocytes are in abundance, that is something which we had seen in those patients who responded to the treatment, and also expression of one of the HLA markers, which was helpful in predicting. But as having said that, these were a little series. We had 5 or 6 patients, and we have built up a few more. And we've always seen that kind of it has a correlation with T infiltrating lymphocytes, but not really with PD-L1 expression.
Have you checked the MSI in this patient too?
We were not checking it in our initial series, but now we are checking it as a routine, and we haven't found any association with the MSI instability as yet.
Thank you.
Okay, Mr. Chairman.
Floor is open for, we still have just less than 10 minutes, so we have time for quick questions if you like to go. Okay, Reda, I would like to just raise one point. The statistics, you said our incidence, our prevalence in Mansoura is quite high, should be taken with cautious. In the routine practice, we don't think that's true, but in hospital-based, because you have a center, you have centralized management now, you get referrals from all over the country, so I am truly confident that the hospital-based will give you a very high incidence, but the public incidence, or the true incidence related to the number of pregnancies and number of deliveries will come down to the average standard that we used to say around 1 to 200,000. So would you please revise that? Because to give to the public the idea that we have an incidence of 1 in 100 or something like that of a gestational trophoblastic disease in common, including the benign and the malignant, I think it is an overestimate. Would you please comment on that?
Okay, thank you, dear Professor. Actually, when we performed the hospital-based incidence, it was very high, 13 per thousand. But when we divide this number of Murad cases over the population in the Kahliya Governorate, it was much lower, half per thousand. I hope when more awareness of our colleagues to send, to refer all cases of trophoblastic tumor to our clinic, to our unit, we will find at the end the population-based incidence more or less equal to the hospital-based incidence. I hope with more awareness, with the non-management of this case in private clinics, the management should be only done in a tertiary healthcare center. This will be a more precise statistics and also will produce a better outcome for the after management of these cases.
Any further questions? Yeah, I get one question for Kristen. Look, for the surgical management, I wonder, you said you could do conservative surgery for that by just wedge resection of part of the endometrium or the myometrium if it is invasive, but that surgically visible, taking into consideration the nature of this disease, which is highly vascular and due to be multifocal. Dr. Kristen Locke, did you get my question?
No, I couldn't hear. There's something with the connection. Can you repeat the question?
Okay, I said regarding the conservative management of cases of invasive mole or localized to a sector of the endometrium and myometrium. Is it surgically visible?
A few words of the question. Neen, could you hear?
Okay, so probably.
I think the connection in Amsterdam is poor, but I could get the question.
Yeah.
I think that all conservative therapies are very experimental, and what you address is that it's hard to visualize a case and it's hard to know where to resect.
Fine.
So indeed, if you look into detail of these fertility sparing procedures in gestational trophoblastic neoplasia,
right,
I think only half of the procedures are successful because you didn't get a clear edge when you resected, because you cannot really see it. And of course there are also bleeding complications if you start a resection in a very vascular womb.
That's great.
So I fully agree.
Yeah, thank you very much. Any further question, ladies and gentlemen?
Hello, yes, it's Raj Naiki. I had one question. Can you hear me? Hello?
Right. Go ahead if you have a question, please.
Yeah, it was really relating to the first case that was presented in the case presentation session.
Right, all right, yeah. Sorry, I missed you. Yeah, please go ahead.
Oh, okay, thank you very much. It's to do with the first case that was presented, and I think you made a very good point about education and awareness amongst health professionals in relation to doing the HCG test. But I also have a question relating to whether there may be a reluctance to do a pregnancy test in a young lady. I accept this lady may be married, but do you need patient consent? And would there be concern in doing a pregnancy test in a single lady? And does that sometimes influence the diagnosis of GTD in Egypt?
Yeah. Yeah. he is just raising the point of awareness regarding a very simple stage that could save life or save the uterus at least. But should we need a recommendation for that from even the FIGO or the international societies to speak about? A very common mishap is to have a positive pregnancy test in a lady that have been training for 3 years for undiagnosed